Paul Banwell, hello.
Hi, Sarah.
I thought we could kick off with some questions. Actually, maybe you should tell us a little bit about yourself and what kind of surgery you like doing first.
Okay, big question. Well, for your viewers, as you know, I'm a plastic surgeon. I'm based in the southeast and in Harley Street. I've been practicing for well over 10 years now, and I have several hats. I have a skin cancer hat. I used to be in charge of one of the largest skin cancer units in the country before I went into full-time private practice, and I still do a lot of skin cancer privately and mole checks. And also because of that, I have a big interest in skin and skincare. And then on the other hand, my main practice is my cosmetic surgery practice, and I do a lot of cosmetic breast work, do a lot of mommy makeovers, labiaplasty, and liposuction, that sort of thing.
We've had the most questions about the breast stuff, actually.
Okay, no problem.
Shall I kick off with some
sure,
breast questions? Okay. So,
I'm not sure I know the answers, but I can do my best.
I'm sure you know the answers to most of them. They're pretty straightforward questions. So someone asked, how do you know as a patient if your implant is ruptured?
Okay, that's a very good question. And the simple answer to that is sometimes you don't. And many implants. So just to rewind a little bit, on average, we know that implants should be changed every 10 years, and that's what the manufacturers recommend, and indeed the government as well. And rupture is actually quite unusual. So the rupture rates now are quoted in the region of less than 4%, so it's actually quite low. But with some of the existing implants, that may be a little bit higher. How do you know? Well, sometimes there may not be any symptoms at all. You may be asymptomatic, i.e. having no symptoms whatsoever, and you might have had a rupture without knowing. And it's only if you then scan, you might find that as an aside. The second thing is that you might get symptoms. So sometimes a rupture can result in a change to the shape of the breast, and it can get smaller or softer. But the other side of the coin is that sometimes that rupture will precipitate a process called capsular contracture, which some of your viewers may have heard about. And capsular contracture is where the scar tissue around the implant, which is usually very thin, and in the majority of patients, the breast is nice and soft. But in a proportion of patients, that capsule starts to misbehave, and it starts to get thicker and starts to squeeze the implant and the breast. And that can happen independently, but it can also happen secondarily to a rupture.
And the other question along that line was, why would you get a rupture in the first place?
So breast implants, well, the first answer to that, I suppose, is there's sometimes, but not always, a history of trauma. So there might be a history of direct trauma to the breast in some shape or form. Often we see quite a few of my patients who've had rupture, they've bashed into something, or they've had a road traffic accident and they've actually damaged themselves, and that's led to a change. And sometimes there's this sort of strange feeling, you can't necessarily see any difference, but my patients would just say, there's something slightly different, I can't put my finger on it, but I think I may have a rupture. And that's when we then start talking about it.
On again in the same theme, let's get all the boob questions out of the way first of all, maybe. Smooth or textured? Somebody was asking.
Very good question. So that's a massive topic in its own right. So have we got time to sort of talk?
Yeah.
Okay.
We do.
So breast implants. Great operation, great patient satisfaction, and it can be life-changing. However, there's also a lot of bad press recently and some downsides that have been described. And so I think it's very important that as plastic surgeons that we're very transparent. We tell our patients what actually is happening, and they can then make a reasoned choice and informed consent. But breast implants are generally very safe. The texture of implants, or the surface of the implants, used to be smooth. So that was the standard breast implants that were available when they were first made. Now we know, we've just been talking about capsular contracture. Now, with smooth implants, that risk of thickening of that capsule, so remember, capsule formation is normal, happens in everybody who has a breast implant. But a proportion of those patients will develop thickening of that capsule. And with smooth implants, we used to see rates of anything up to 40 to 60%, so sometimes quite high.
That's a lot.
And therefore, clever scientists decided, and the companies tried to develop a method of reducing that capsular contracture rates. And they went about that by creating texturing on the outside of the implant. Now, that texturing was a significant and a major contribution to decreasing capsular contracture rates globally. And so those capsular contracture rates came down with textured implants, which have now been renamed macro texturing. And those implants therefore reduce capsular contracture rates, and also for when anatomical implants, teardrop shape implants, were used, it helped the implants stabilize, because one of the problems with smooth implants is that they can move around. Now, as with all things, whilst that was a significant advance in breast implant technology, that reduced capsular contracture rates from around about, as we said, 40% down to about 10 to 15%, and some of the manufacturers were actually quoting less. But more recently, it's now become apparent that whilst that texturing was initially very good, there's a downside. And that downside is a potential association with a very rare cancer lymphoma called ALCL, or BIA-ALCL. Now, what's interesting is that there's been quite a lot of media attention on this over recent times, and obviously it's created a lot of anxiety amongst patient group, quite rightly so. But we need to put it into perspective, and we need to be transparent. A lady's risk of breast cancer is about 1 in 8, okay? But the risk of ALCL is 1 in 25,000 to 1 in 60,000. Wow. So when you start looking at it, in actual fact, when you compare that and look at the figures and put it into perspective, then obviously it's extremely rare. But nevertheless, we still have to talk about it, we have to discuss it, and we have to find ways to improve it. And indeed, what's become apparent is whilst that texturing was initially developed to improve stability and to increase the biocompatibility and reduce capsular contracture, it's now been shown that in actual fact that may not be the case. And so there have been some very clever scientists, in fact in the UK, Professor Adi Bayat, who's based in Manchester, he's developed sort of what's called a nanosurface. It has been reclassified as according to the new ISO classification, it's been classified as smooth. So it has a very nano-textured surface, but it's been classified as a smooth implant. So it has the benefits of a smooth implant to reduce inflammation, and there's no reported cases of ALCL with these implants at the moment. And because of the fact that it's a hybrid, it's not macro textured and it's not smooth, even though it's classed in the smooth category, it actually reduces capsular contracture rates as well. And so that for me is quite an advance, and that the company that sort of innovated those things is called Motiva.
I'm kind of confused as to why having a different texture but the same material would cause this problem.
Yeah, no, you're right. It's all about, and again, we're still learning that it's about how it's made. So the manufacturing, we think that with the ALCL story, that particularly how the texturing was created with other chemicals and salt, for instance, has contributed to this inflammation that can then potentially lead to this very rare tumour.
That's really interesting. Somebody over on YouTube asked, can you breastfeed with a ruptured implant?
Okay, so it's a very good question, and thank you for asking that. And we see quite a lot of patients who come in. Obviously, it's a time of great joy, excitement with having a baby, which obviously you should enjoy in motherhood. You can. So there's no evidence that you shouldn't be able to breastfeed. Bearing in mind that in the food chain, and Sarah, you know a lot about this already, that we get silicon within the food chain, and so babies actually get a lot of silicon anyway within baby foods and within the food chain. So we don't think that it has a major effect, but again, nobody really knows, and the only way to be certain is obviously not to do so. But many girls will still breastfeed, and then once they have that over and done with, then obviously you can think about potential exchange of implants or removal.
And I don't know if you saw, but somebody asked on Instagram, can somebody tell when you're getting physical with them by feeling the breast that there's an implant in there?
Right. Again, really good question. So, sex. Is it possible to feel the implant during sex? Well, again, with some of the newer, the answer is sometimes yes.
Yeah.
And that will be obvious from some aspects in terms of scarring and in terms of the appearance. And if you've got very large breasts and they're very obvious, then that may arise an index of suspicion.
Yeah.
But it all depends on your tissue envelope. But the answer is that we can. I saw somebody recently who's a lovely girl, had a fantastic aesthetic breast, and her scars, she had inframammary scars. And I saw another patient with more rare but had periareolar scars, and they looked extremely natural. You couldn't feel them; they just felt like a normal breast. In actual fact, the implants I've just been talking about, the Motiva ergonomics, they've been developed specifically so they feel like normal and very natural breast tissue.
Wow, that's interesting.
Which is it's very exciting.
What's the weight on them?
Well, that depends on obviously the size of the implant, so they will vary depending on the size of the implant.
Because I understand that there are some lighter implants available now.
Yes, so they're called B-Lite implants, and that was they were developed by an Israeli plastic surgeon and his brother, very clever people. And the concept was that they had little microspheres within the implant. They're textured, so they still have the same problem that we've just been talking about. So they're not made in the new sort of smooth shell and surface. But the problem with them, whilst they are generally, or they were touted as being 30% lighter than the equivalent implant, especially at it makes a difference when you start to go larger. The problem is that they do feel slightly different to normal breasts, so they feel a bit like a memory foam mattress. And so whilst they're very exciting, and some girls, for them, the weight and the lightness of the implant is really important. And of course, they would need to make their own decision in terms of whether or not they like the feel. I have tended now, as I've just been saying, that I sort of use one particular brand now simply because of it's about minimizing the risk of ALCL, minimizing the risk of capsular contracture, minimizing the risk of rupture. So I don't tend to use those anymore unless a patient specifically asks.
You've had a happy customer over here on Instagram who says that she's very happy with the implants that you did for her back in February. So
great.
That's
hello.
Speaking personally, of course, you did mine about maybe 4 or 5 years ago now. I can't really remember. And underneath, if I make a certain kind of movement, you can feel it. I'm just answering the patient's question, but it's never been anything which has concerned me.
Yeah. So as I discussed with all my patients, and as I had explained then, it's normal to be able to feel an implant.
Yeah.
So you will be able to feel especially when you lean forward, inferiorly, you can always usually feel the implant. If you're very, very slim and you've got very thin skin with a very thin skin envelope, you will feel the implant. And it's really important that girls understand that. And also the fact about rippling. People ask about rippling.
Yeah.
Now, rippling happens in everybody. When you move, the implant moves, and therefore the implant creases. The question is whether or not you can see or feel that rippling. And if you've got a big breast to begin with, starting off, or you've got a thick tissue envelope, or you've got good quality skin, or you're going for a small implant, comparatively, then you won't feel that as much. And sometimes you won't be able to feel the implant at all. But I always tell my patients that you will be able to feel it, especially if you lean forward. Yeah.
We've had an under or over the muscle question on Instagram.
Great question. Again, your viewers are on fire, aren't they?
They are
today. So that has to be based upon a bespoke approach, discussing with the patient their personal wishes. Number one is really important. So it's important that I always listen to what they want. The second thing is about their start-off breast, how big it is, the quality of what we've just been discussing, how big the breast is, how thick the skin envelope is, their body shape and habitus, i.e., are they very skinny, are they more curvaceous? All of these things influence that decision. Also, it depends on the size of the implant as well and what they're choosing. So all of these things we're taking into consideration, and it's very much a tailored approach for each individual patient. So sometimes a patient may have the option of both, but in actual fact, depending on their appearance or their desire for their implant, or the look they want, they might need to have one or t'other. So again, it's very difficult to answer that question generically, and we have to identify that in a particular patient, and obviously we go through that at consultation.
That's a good question on Instagram. What's the difference in result between implant and fat transfer? Do you do breast fat transfer?
Yeah.
Yeah.
One of my specialty areas, yeah.
Tell us.
So what's the difference?
Yeah, like how does it look afterwards?
Yeah, so basically it's a great question as well. So implants still remain the number one cosmetic procedure globally. And the second, varying between liposuction and breast augmentation. So with the advent of these newer quality and newer technology implants, we've started to address some of the issues that we've been discussing, which have been addressed ongoing over the last few decades. But there's also a move now towards combining implants with fat, and that's called hybrid breast augmentation. And my particular technique is called HYBA, HYBA, hybrid breast augmentation. And that's a combination of breast augmentation using an implant as well as fat transfer. Now, one of the problems about fat transfer that you'll be acquainted with is, in the old days, a guy called Sidney Coleman invented fat transfer, and he was very clever, and he used it for a lot of facial stuff, and then it started to be used for breast. But the problem was the way in which we processed that fat meant that we lost a lot of the take, because it's a graft. It doesn't have a blood supply, and we have to move it from one place to another in the body, and then it needs to gain a new blood supply. And if you try and put too much in, then sometimes that fat will just die. So you get a sort of reabsorption rate associated with the fat. And therefore, repeated transfers were always recommended. Now, the problem is that now, so that was the state of affairs. Now we have improved understanding of what is going on with the fat take rates, and there's some new techniques that have been developed to increase and improve those fat take rates. And there's a system that I use, PureGraph system, which actually helps improve fat transfer take rates. So we've now got the facility for improved fat processing, improved fat take rates, and therefore we can then combine these, and again, we can tailor it, especially with computerized design. We can tailor implants and fat. I also use, I'm sure you do a lot of nano fat as well, but as many of your viewers will know, fat, what we're talking about for fat transfer and breast augmentation is for volume. Mm-hmm. So volumizing and for contouring. So it's very good to put in the upper pole of the breast, mm-hmm. and to improve the sternal area, the cleavage area, especially in those patients that have quite a wide sternum and their breasts are actually placed quite slightly wider apart. So you can actually get an improved cleavage appearance with fat transfer to this area. But the other thing that you're aware of is that fat is one of the most prolific sources of stem cells. Mm-hmm. And so we can then start to use nano fat transfer techniques to improve the quality of skin, especially for girls with thinner skin. Mm-hmm. So not only are you using fat for volumizing, you're using fat for improving quality of the skin as well. So that's what I do for my HYBA technique, is that I use it implant, Motiva implant, fat, but I also use nano fat as well to improve the skin quality too.
We've also had a question about the mesh that some people are using.
Yeah, so meshes are used as an internal, or have tried to be used as an internal, sometimes called Brava. The problem is that so this is used for breast uplift to try and avoid scarring or more significant scarring associated with an anchor pattern scar. The problem is all of these techniques that have been developed, unfortunately, their longevity in terms of how long they last is not proven, and so the problem is that it doesn't necessarily always work, and that is. Oh, what happened there?
You disappeared,
Sorry.
But you're back.
So, I'm back.
Yeah.
Thank you. Sorry. So it can work in some people. I'm not a big fan of it personally. There are surgeons out there that do like it, but my answer would be, if it were really successful and really efficacious, then everybody would be using it, but they're not.
Yeah. Does that make sense? Does the mesh stay there? Is it a permanent thing?
It reabsorbs. Well, there are different types of mesh. And it creates scarring, so it acts as a scaffold. But as I said, the problem is that there's also a risk of infection with any foreign body as well. So you want to try and minimise that. So I personally have little experience with it, and all the people I know that have tried to use it have actually only used it for a short while and then gone back to other techniques.
It's a shame, because in theory it sounds like an interesting idea.
Absolutely. And in actual fact, I think we will see what happens. I think this actually is quite an interesting point, because with technology generally, there will be first generation, second generation, which may not be that good. And then all of a sudden, the concept is great. Absolutely. But it's not just about the concept, it's about it's the delivery of that concept. And sometimes you need to play around with that concept to enable it to work. And so you might get, like, the third or fourth iteration might then actually be the success. So I'm not saying it's not a good technique. I'm just saying it's not a good technique at the moment.
Yeah, understood. I suppose that was the same case with fat transfer as well, because it wasn't very fashionable, was it, a while ago?
No, absolutely. And there were limitations because of the take rates, and therefore the results were sometimes fantastic and sometimes disappointing. And patients have to understand that there's not an exact science, and therefore we have to lower expectations and make sure that we talk to them very carefully about all of that. But historically with fat transfer, you're right that it was an issue, but that's now changing. So we've got our techniques are improving all the time, the research improving. Therefore, I think, going back to what you said about the scaffold, I think the whole scaffold story is really interesting, because the impregnation of these scaffolds with stem cells, with other growth factors, etc., is going to be quite exciting, and to give that structural support. So I think that's something to look out for in the future.
Another question that I had was about the shape of the implant, so teardrop or not.
Right. Again, very good question. So traditionally there were only round implants, and those round implants had a maximal, obviously they were round, so the diameter is the same, and they had the most projected point is the middle bit. So they had a very convex upper pole, and many people, so I've got something come up on my thing.
Here we go. On Instagram. He's back.
So
he's back.
Thank you.
You're back.
Something happened. Did something happen then?
Yeah, you disappeared from Instagram.
Oh, did I?
Yeah.
Okay, I'm so sorry about that. So there was just something came up on my phone. I don't know what it was. So basically, I've lost my flow now. What?
You were talking about the width of the implant.
Oh, sorry. We're talking about shape of implants, weren't we? So that's round implants. Then people started to say, well, breasts are not necessarily just round, stuck on. Is there another method can we design something that looks more natural? And therefore, anatomical implants were designed, teardrop shape implants, and they had their most projected point much lower down the breast. And so for those girls with slightly lower nipples who didn't want a mastopexy uplift, which the attendant scarring, could actually use an anatomical implant and actually create a very natural looking breast. But also for girls who didn't want a very obvious upper pole and wanted a very smooth upper pole shape, then it was very useful. And I used to be a big fan of anatomical implants. I used to use a lot of them. But remember, they were textured. Mm-hmm. So you can't use a smooth implant because it will just move. And one of the problems, again, probably underestimated, maybe overestimated, is the fact that you can, with anatomical implants, they can actually rotate. And obviously that can cause distortion of the breast. Mm-hmm. Now, more recently, going back to the implants I was just discussing earlier, the Motiva implants, they've revolutionized that whole concept of round versus anatomical, because they've come up with, in effect, which is a hybrid system, which is something called ergonomics. And it's very clever. And it means that the gel that is made is very soft, very pliable, and it feels like in effect, like a real breast. And when a patient moves, either stands up or lays down, the breast will move as well. But the significance of that is that the gel will actually move. So when you go into an upright position, the most projected point, even though when you're horizontal, the most projected point is in the middle, when you're actually vertical, the most projected point will actually move like a normal breast.
Wow.
And so those have really, have revolutionized my practice, and my patients love them because they're so soft, and you can then avoid the need for anatomical. So I very rarely use anatomical implants now for that reason, because it's a game changer. They've just changed the way in which we think about traditional round versus anatomical.
I got to tell you, you're selling it to me. I'm feeling an implant change coming on here. Really, they sound fantastic.
They are, well, I don't get excited that often about, because even though I'm an early adopter, I'm also very cautious, and I think it's important that I'm cautious and safe on behalf of my patients. And so, everybody's now realizing that that the innovations that they have just sort of have created a bit of a exciting storm in the industry, because they're so revolutionary. The other thing that they do is that many girls, this goes back to the PIP implant crisis when there was some potential issues there. Many girls did not realize which implants they had because they'd lost their information. Mm. And obviously I would implore everybody just to keep that information to hand, because it's really important. But what this company have done, Motiva have done, is that they've actually put in a little microchip transponder. Wow. Which means that we can put a little machine up against you, and we can see when it was made, the lot number, so all the safety data. So you've got that reassurance of knowing that even if if you're out on a cruise, on a boat, on the way to Capri, for instance, and you happen to have your breast implant information, and you happen to let go, and it went to the bottom of the Mediterranean, then no big deal, because your chip could be read very easily.
That's insane. I love
it's
that
insane.
idea.
And what's really interesting is that now they're increasing, they're changing that microchip transponder. I mean, it's teeny. They're now developing temperature regulation, which might indicate pressure regulation, which might indicate rupture. Wow. Or infection, early infection, which might be leading to capsular contracture. It's fascinating, some of the stuff that is coming out.
That's insane. So somebody on Instagram asked, breast asymmetry, what's your approach? Different size implant or fat transfer to create more symmetry?
Great question. Very difficult to answer without actually seeing a particular patient. So in essence, it's very simple. You can do nothing or you can do something. And if you do something, and sometimes we have to, I know that sounds a bit trite, but it's really important that sometimes doing nothing might be the best option.
Yeah. Mm-hmm.
And we're here not to necessarily do an operation. We're here to give good advice. Yeah. And so we have to bear in mind that doing nothing doesn't create any scars, doesn't create any potential problems, and therefore we have to give that as an option. If you do something, the approaches are you could try and match one of the breasts. You could operate on one breast or both. You could create a reduction in one. So if you had, say, the right breast was larger than the left, you could reduce the right breast to try and match this to match the other one.
Mm-hmm.
And it could be that your size match would be sufficient in your clothes and in your bra and underwear and swimwear. But sometimes you then have to do other ancillary procedures. So you might need a lift, for instance, in one, and an implant in the other side. And going back to what I said about a bespoke approach, my approach has always been bespoke and tailored to the individual. And I think breast asymmetry is a classic example of that. You have to discuss those options because you've got breast reduction, mastopexy, augmentation, asymmetric augmentation, and fat transfer all in the mix that you can play around with depending on what the patient wants. Mm-hmm. Because, of course, if you've got breast asymmetry and you want larger breasts, that's different from just trying to balance the breasts. Or if you've got breast asymmetry with ptosis, i.e. a low nipple, then that's a very different algorithm, a very different approach, treatment strategy for that particular patient. So it will vary from patient to patient.
That's interesting. Speaking of the ptosis, scars after somebody has had an uplift, how bad is it?
So uplift surgery is very common, and many girls will decide to go ahead with uplift surgery or breast reduction surgery. However, many girls wish to avoid that scarring, and that is a difficult decision depending on their existing breast shape. So often, breast augmentation does not lift a nipple. It can minimize descent of the nipple, and sometimes it can give the appearance that it's actually higher than it started off, but it doesn't physically do so as with a breast uplift. The problem is with a breast uplift is, as we were just discussing earlier, is that it creates scars. And there's different scarring pattern that is associated with an uplift. And the problem with ptosis, so ptosis is just about the position of the nipple. And it's graded in different grades by plastic surgeons. But basically, the lower the nipple, the higher you have to move it up. And the higher you have to move it up, the more skin you have to take away. And therefore, the more skin you have to take away, the more significant the scarring. And essentially, there are three patterns. There's a periareola, just around the areola. There's a lollipop, which is around the areola and straight down. And then there's an anchor pattern scar straight down with a scar going underneath the breast. And sometimes you can make that scar short. So that's a short anchor pattern scar. So essentially, that is as a result of you doing three things. You're lifting the nipple to a higher position. You're then taking away that skin excess. And by taking away that skin excess, you're reducing skin, you actually skin excision. But by creating a tighter hammock, that breast tissue will actually stay slightly higher. The problem is that over time, that breast tissue will then come back down again. So again, you can often use fat transfer to get some upper pole fullness, or you can actually combine breast uplift with breast augmentation.
That's interesting. Somebody on YouTube has asked, when a person has a pointy but low-hanging A-cup breast, like with a lot of skin and not a lot of fat, how
from weight loss, sorry, or just from just generally?
She didn't specify. She just said, does the size restriction that you can go up to, is that related then to the amount of soft tissue? Because she says here, oh no, here we are. She's followed up. She said because her breast is quite high still, but she wants to have them bigger, I think.
Okay. Again, without seeing and measuring and having a chat and hearing exactly. So the answer is there's no reason why she can't have an augmentation, but we'd need to see and examine her and then go through that in more detail. Yeah,
of course. Wow, I think we've talked for like half an hour just about breasts. It's quite a big topic, isn't
Wow. Okay. Oh, huge. And it is. We could talk for hours because breast. It's like tip of the iceberg, isn't it? You can hit a little bit here, but there's a lot more underneath. And once you start, just as we found out here, we've sort of been jumping around different subjects, but you can go down certain avenues, and then it's a big discussion in its own right.
Yes.
But I think the most important message is very much you should have a bespoke approach. Google is a great thing, but when it comes down to it, there are nuances and subtleties that that patients should be aware of. And the other thing that is important as well is that you can have different approaches to the same problem.
Yeah.
So often there may be, and that needs to be discussed with the patients as well, and then they need to take an informed decision at which approach they would like.
Somebody's asked about, she said, I'm curious as to what can be done for a slim person who's young but has a lot of cellulite. Do you do anything with that?
Right. So what, on her legs?
Yeah.
Okay. So unfortunately, this is, well, you probably do slightly more cellulite treatments than myself, I'm sure, right, with energy devices. Surgical, so there's no, cellulite's one of those conditions, and I'm sure you've discussed it on your channel already. And David, your good friend as well, David Jack, we were sort of,
he's watching
he
now.
talked about that.
You see.
Oh, hi, David. So he gave a really good exposition on sort of the non-surgical approaches for cellulite earlier in the week. And the problem is surgery is very difficult because there is a technique called self-fina, which is sort of a pseudo surgical technique, but the results are all very, none of them are totally satisfactory. So whoever invents a technique to get rid of cellulite will be obviously a very happy and wealthy person. Mm-hmm. You have to think about obviously lifestyle factors, and all of the non-surgical approaches that you offer in your clinic, I think, are important. But from a surgical point of view, unfortunately, it's very difficult. You can minimize it. So, for instance, in the legs, if you've lost weight as well, then just doing sort of a lifting technique, a thigh lift, can actually minimize the appearance of those skin changes. But it doesn't actually improve those skin changes with surgery. It just disguises it. Yeah. And therefore, you have to approach the actual skin itself, yeah, and with energy devices and skin tightening that have been described.
Yeah, I do mesotherapy for that, but this isn't about me; it's about you.
Yeah, no, exactly, and that can be really useful. But that's a non-surgical technique; it's not surgery. Yeah.
So butt implants.
Okay. So buttock implants. So the problem with buttock implants is they almost always need to be removed because they move. Buttock implants are very popular around the world, less so in the UK. So different people have got different views about them. You can get some nice results, and you can create some small scars, but the problem is they can move. And so it's really important that patients are aware of that. So the reason why fat transfer then became so popular was because of the dissatisfaction with definitive buttock implants because of the technologies. Having said that, I've just been talking earlier about the company that have been developing breast implants. They're also trying to have a specifically engineered buttock implant as well that is more natural. But because of these issues with buttock implants, there was a move towards using fat transfer as an alternative. But as you're aware, at the moment, the British Association of Aesthetic Plastic Surgeons have recommended that that's not performed in this country. And the reason is that there's a very high risk. If in South America, for instance, they recommended intramuscular injections. And as you know, because of the vascularity, that has the potential for fat embolism. And so that has a very high mortality rate. Having said that, at BARPS recently, which is our association, last year, there's a very, very good debate and some fantastic presentations by some very famous surgeons from the States, and they were basically saying, look, in actual fact, it can be done. It needs to be done by plastic surgeons, and it can be done safely, and that you can get some great results, but you have to follow the rules, and all of the issues with the high-profile sort of media cases have all been done by people who are not fully trained plastic surgeons.
So, confession, before this whole coronavirus issue was a thing,
so
I was supposed to be having... I just disappeared because my battery's running out. I was supposed to be having, with Dr. Aslani in Marbella, my butt done. And so he uses a dual technique, maybe in the same way that you are with the breast.
He's very, very good, very nice guy.
Where he uses the implant and then he puts fat over the top.
Yes.
Is that something that you would see happening here?
Yes. Again, what we were talking about before, I think he uses those implants as well that I'm talking about. So, and it's about trying to make that implant smaller and using more fat, and it's that relevant or relative proportion of each of these, which is actually quite important, and so that's the concept of the hybrid techniques is now being applied to buttock augmentation as well.
We had a question on YouTube about noses. Can you reduce cartilage in the tip of the nose by going, I think they mean a closed procedure. Can it be done as a closed procedure?
Yeah, so for your viewers, as I'm sure most of them know, there's two different techniques. There's an endonasal closed approach and an open tip, an open approach. I don't do rhinoplasty. I used to do a lot of rhinoplasties, but over the years, I'm now focusing on other things, as I've just said. But essentially, yes, you can. Very accomplished rhinoplasty surgeons always used to use an endonasal approach, and you can do lower lateral cartilage manipulation and tip work closed. It all depends on the problem. It all depends on the patient wishes and what they're hoping to achieve. Ultimately, however, globally, most people believe that an open approach gives the best results because you can physically see what you're doing. You can consider more fine tip work, grafts, spreader grafts, etc., which can help give a better result. So whilst it seems as though there is a little scar and it does take longer for the swelling to settle down, it is a much better result and you get much more refinement in the technique.
I think we should talk about labiaplasty because we've only got like 15 minutes left before Instagram cuts us off, and this is going to be a really hot topic. So who's doing it? How'd you do it? Why would you do it? Okay.
So as you know, I've written a book on this. I have the dubious honour of having written an Amazon bestseller amongst plastic surgeons, which has just been I've just received my copies of. It's just been published in 3 languages now, in Polish and in Chinese as well. And we're just doing a second edition shortly. So labiaplasty is a very increasingly popular procedure. It can be done for functional reasons, for discomfort in clothes, gym, doing exercise, cycling, horse riding, often following children as well, but also for aesthetic purposes. The problem is it's controversial, and it's important that we recognise the controversies and that we're open and transparent about it. But also we need to realise that the decision is a personal one, and we have to discuss the risks and complications. One of the things that I'm particularly interested in is that the anatomy of the vulval area, the external genitalia, the labia, vary enormously, just as in male genitalia as well. And one of the things that I've made a big point is that up until now, because it's so popular, it's one of the areas of surgery that really hadn't been focused on, and there was very little published. And so there's a huge variation in anatomy, and the variation in anatomy will actually depend on how you do the technique, and it's important to point that out to patients. And that's been one of my things that I've been sort of teaching globally, is about the variations in anatomy of the labia and how important that is. But I think it's the patient satisfaction with labiaplasty is huge, and it literally can be life-changing and very empowering for my girls. Yeah.
Are you ever doing fat transfer?
Good question. So, to the labia minora or the labia majora?
Majora.
You mean to the labia majora? Yeah. So labia majora fat transfer is called labia puff. And labial puff is a technique for a deflated labia majora. You can improve the volume to the labia majora and help. And that sometimes can be done alone or in combination, albeit maybe in 2 stages, with a formal surgical labia majora reduction. Also, there are techniques, Desiria from Vivacy, which is a French company. You can actually use filler to fill the labia majora as well. And so we have a number of different techniques. There are also external energy devices that can be used to help tighten, and they can have variable results ranging from fantastic to minimal effect. But it's a very exciting area. The whole area of sexual health and well-being is increasingly important, and I think we need to recognise that. And it's something that it's important that we talk about, and we need to listen to our patients.
You ever work with women who have had FGM?
So I personally, obviously FGM is a very controversial subject. Obviously, it's illegal. The problem with labiaplasty surgery per se is that one of our previous Prime Minister, who also was then Home Secretary, put labiaplasty in the same category as labiaplasty. And when I tell my patients that, and then they look at me aghast and they think it's it can be further from the truth. Yeah. But FGM itself is obviously something that is a terrible thing that happens around the world. And I teach at the Dubai conference, and there are some fantastic surgeons who actually help these poor girls following FGM as well.
But that's not something that you've seen here.
No, I personally have never seen it in my practice.
Yeah, I have a technical question actually about when you're using the Desiria. How much do you normally put in?
Well, it all depends. It all depends. So again, you discuss with the patient. The problem is volume, and then so it comes in a little. I haven't got any here actually, but. It's at the clinic, which is unfortunately shut. But basically, it depends. Every patient is different. You much prefer to underfill and come back and do some more than to overfill. You do get some reabsorption. You have to be careful about molding it. I can show. I have got a video. I've done some videos of some patients who have given me permission, so I might. I can actually. Discuss that and show that at some stage as well.
Oh yeah, I'd love to do an actual YouTube video about that, because that I think would be really interesting.
Yeah, I'm more than happy. So I'm working. I'm starting to work. So one of my big things is about anatomy, and I think it's really important that the first thing is that I reassure all my patients that their anatomy is normal. Yeah. There is a normal spectrum, and some are in. At one end or t'other. But what's interesting is that it affects people in different ways. So the problem is that we can't judge in any way. And for people on the other side who do judge, I think it's really important, because they don't realize sometimes some of the symptoms that can occur, even if comparatively somebody might have quite small labia. But if they're really slim and their labia comparatively with someone else may be much smaller, they can still cause quite significant symptoms. And so I think you have to take it on a case-by-case basis.
Are you also using the Desiria that comes in the yellow box too? You use that one as well?
Yeah. So that can help moisturize internally. The whole concept here is improving sexual function and well-being. The problem is going back to, rather than fillers, but going back to the energy devices. As you're aware, the FDA came out with were concerned last year that there were, was it last year now or the year before? I've lost track. That there were some, let's say, practitioners and companies were claiming things outside of their recommendations. So obviously it's being recommended for stress incontinence. And the thing is that we're now finding that these techniques are actually very useful and they can improve sexual health and well-being, but we need more studies and more work. But undoubtedly they are, it's very exciting. The whole area is growing, but we also have to be careful that we don't that patients are given full information and that they understand what things can do and what they can't. So we've got to be. So these companies were criticised in terms of marketing or over marketing to patients.
Do you have any energy-based devices for this?
I don't. Yeah. No. So I do most of my referrals from other doctors and indeed directly to me will be for surgical techniques and for injectables for labial puff.
Yeah. Can I ask about the anesthesia that you're using for that?
Yeah, so you can do both. You can do topical anesthesia, but you can also put a little block in as well, and that's up to you. That's up to you. That's a personal choice. Most patients, I do a lot of it actually when they're actually asleep as well. So I don't have that issue so much because I have the luxury. I have the luxury of my patients actually being asleep for that. So that's a benefit. But most people would just use local anesthetic, both topically and infiltration.
Yeah, I must say, because I use Deserial as well, I do an infiltration. Otherwise, it's a bit.
Yeah, it can be. It smarts, and but yeah, I would recommend using local anesthetic definitely.
I think we've got time for one more question before we get
go for
off, it. Which is loss of sensation after breast augmentation.
Right. So once you enlarge the breast, you're going to stretch the nerve, and when you stretch the nerve, that does one of two things. It makes the nerve fire off 100 miles an hour, but it also can stretch the nerve, and then the function will decrease, i.e., you can get numbness. Usually that's around the nipples, but it can also be related to other areas on the breast as well. Usually with massage, nipple desensitization and massage around the breast, it will get better, but it can take time, and it can take anything up to a year for it to settle. Most sensation improves within a few months.
Just on that topic, to answer the question, it took longer than a year for me.
Yeah.
Actually, it took 2.5 years.
That long. So that's more unusual. So that is unusual because most people. But remember, everybody's nerves are different, and so again, the most important thing is that you tell patients that you're going to, you knew that is a potential. And therefore you're prepared for it. Yeah. So it's not that it happens. It's a question of then how do you manage it. But you've got to keep massaging. You've got to re-educate the nerves, and it will come back. It's very rare. I've never seen a abnormal sensation that hasn't got better.
I'm just having a feel now, actually. And here I can feel, I feel like it's a consultation now. Underneath I still can't. But it doesn't actually bother me.
Yeah.
Not being able to feel that. It's okay. I think it's the same with any procedure, isn't it? You kind of imagine, or the patient imagines how it's going to be, and then it's never quite like that in real life afterwards. Do you know what I mean? Because
well, everybody's patient experience is different. Everybody's journey is different, and and we try. It's as for all your patients as well. We always try our best for our patients, but everybody's journey is slightly different. But it's about giving them as much information as possible and preparing them for the outcome and what is going to happen.
Yeah, totally. No, but I was thrilled. But those Motiva things, they sound.
Yeah. No, it's really revolutionised things. So.
Yeah, that sounds really up my street. Okay, well, I think I better go before we get cut off.
Sarah, lovely to see you. Lovely to chat, and thank you to all your listeners.
That was good. Thank you so much for
tuning in.
coming on. Thank you.
It's a pleasure. Bye bye now.